Oncologist, that is a cancer specialist. Thank you for having me. Janet gave me a topic to just go through an overview of common cancers that we have today, that we commonly see in this day and age. So this is data that I've picked from a WHO site. I'd say it's credible, though just a disclaimer, we are very poor in collecting material, in collecting data. So this is gross underrepresentation of the true number of cancer cases in Kenya. That being said, we still know breast cancer is the most common cancer in Kenya. This is in 2020, but this reflects well into 2021. Cervix cancer, that is cancer of women, is the second most common. Prostate cancer, this is affecting men only. Esophageal cancer, this is cancer of the food pipe, is going to be number 4. And the 5th is colorectal cancer. This is cancer of the bowel, the large intestines. So, if we're going to pick 5 diseases that are most common in Kenya in this day and age, these are going to be the most common. Again, gross underrepresentation of the true numbers, but this sequencing is correct. So why these 3, majorly these 3 cancers, they're big numbers. We see huge number of patients coming with these diseases. They are major cause of premature death. I'll just say disease and death. There are effective interventions to reduce the death from these cancers. The prevention of this cancer is at a relatively low cost. I know, for example, a breast cancer mammogram for women costs about 4,000 Kenya shillings, and this is only done maybe once a year. Colon cancer, again, it can easily be tested by stool. So a stool test, I doubt it's even more than 1,000 shillings. And cervical cancer, we do pap smears, again, a very low cost test. So these are diseases that can be prevented and deaths that can be prevented. So starting off with cervical cancer, what causes this disease? It's caused by a persistent viral infection. Putting it very simple, we know viruses cause infections, for example, coronavirus, but this time it's going to be the HPV virus, the human papilloma virus. There are very many different types of the HPV virus, but there are some very common ones that cause the cancer. There's some notorious ones. We call them, so they're grouped serovalent 16, 18, 33. Many of them you don't need to know, but we know for sure 100% cervix cancer is caused by the HPV infection. So it's a slow growing cancer, and it starts as a pre-cancer lesion, pre-cancer changes. So if it's slow growing, this gives us an opportunity to prevent this disease. It gives us an opportunity for early detection of the disease, and it gives us an opportunity for treatment of the disease when it's still at the early stages. All this in summary means this is a disease that can altogether be eliminated. So what are the risk factors of getting this cancer? Low socioeconomic status. Why I say this is because, for example, in the Western world, the #1 cancer for them is going to be lung cancer. Cervix cancer is almost nil in their part of the world. We know in the low middle income countries, cervical cancer can almost be the #1 cancer killer in these countries. Why this happens? Maybe it's related to our behavioral patterns, cultural patterns, and all this. So the other risk factor is nutrient deficiency. Of course, this is going to be related to low socioeconomical status. Genetic factors as well, though the number of people going to be affected because of genetic factors is very, very low. Viral factors, I would say HIV. HIV infected people are at a significantly higher risk of getting cervix cancer. Tobacco use, tobacco is cigarettes very commonly for us as well. High use of oral contraceptive pills, multiple sexual partners, and I'd say that is the most significant risk factor for us. So what happens with multiple sexual partners? You find if someone is promiscuous, they are essentially exposing themselves to multiple infections of the HPV virus. Remember the HPV virus that was causing the cervical cancer? Most people actually have it, but it's asymptomatic, meaning you don't feel anything, you don't secrete anything when you're having this infection. And by the way, the infection is in both men and women. So there's a lot of sharing of the infection, but someone may be having it without even knowing it. So you have this infection for quite some time, for a good number of years, actually. Eventually, it leads to changes that can cause cancer, that will cause cancer, actually. So multiple sexual partners, we know this is a very, very big risk for cervical cancer, and it's actually highly associated with low socioeconomical status. So those are just a few things we at least can control, and poor personal hygiene as well. So how do we approach this in terms of prevention and control? We look at it either as primary prevention, secondary, or tertiary. Primary, we target the very young girls, and for these girls who have not been exposed to the HPV virus, remember the HPV virus is you can only be exposed to it through sexual intercourse. So we believe these girls have not been exposed to these activities, so they are perfect candidates to get vaccination. I know there was a bit of controversy about the vaccination, but from a lot of research that we've had, we know this is a safe vaccine and it prevents the cancer developing up to 100%. So the vaccination can also be offered to boys as well. Remember, the HPV infection can either be on girls or boys. It's just not isolated to women alone. So we can also cancel this age group. They're still young, about sexual education, condom use. Male circumcision has also been associated with cervical cancer just because of the harboring of the HPV virus and the personal hygiene related issues. So for secondary prevention, we are targeting women above 30 years old. So what are we doing at this point? At this point, we are already past the vaccination point, and we just want to screen these people and treat them as soon as we get any sign of the cancer. With this, we do the pap smears, we check for HPV virus, and the minute we get anything suspicious, we act on it. What about tertiary prevention? So these are people who already have the cancer, and at this point, all that we can offer is treatment. So I think what I would advise at this point is just to focus on referring the patients who have been diagnosed with cervical cancer to excellent centers that are going to be offering good quality care. Because again, having offered this treatment to a lot of patients, I know a lot of patients can be cured of the disease if it is caught at a very early stage. So, I also find a lot of patients waste time in the peripheral facilities being told, oh, this is just a simple infection, this is what. So the minute we get these patients, we have to refer them to care facilities that they can get the care they need. Women ages 25 to 69 should have a pap test every 3 years. The screening of abnormal cells, if we screen and we find abnormal cells in the cervix, this can be treated early and they can stop the cancer from developing. Just with this pap smear, we reduce the risk of cervical cancer by 70%. That's a lot. And if we get the cancer early by the screening as well, this is the pap smear, we reduce the chance of death by 85% from the cancer. So for example, we get a patient who unfortunately already has the cervix cancer, and we treat it as soon as possible with the right facilities, we've reduced the chances of death from this disease by 85%. So how often should a woman do a pap test? The pap smear, I'm sure it's very common. Most of us would know it. Under the age of 21 years, we don't recommend the testing. But then again, I'd say the caveat to this is how soon was the individual exposed to sexual intercourse? If this person has been exposed to sexual intercourse quite early on, it means that they've had a possible HPV infection much earlier. So the changes in the cervix might have happened. Either way, that being said, we still don't recommend under 21 years old. 21 to 30, we do the pap test every 3 years. And 30 to 65, this is the most common age that we catch the cervical cancer. So again, we do it every 3 years, or if we can access the HPV testing, because we can actually test the virus itself. If we can test it, then we can test it every 5 years rather than the 3 years of the pap smear. 65 years or older, no testing needed, especially if they've had good consistent testing for the previous years. So what are the signs of this disease? Women would be presenting with unusual vaginal discharge, abnormal bleeding, heavier or longer periods, discomfort while urinating, maybe a burning sensation, or it's just not feeling right, and loss of bladder control. You find like they feel like they want to pass urine, but they don't have control of the sphincter and it just passes involuntary. Pain during sexual intercourse and constant fatigue. Unfortunately, when it gets to that point, it just means the cancer has already spread. Pelvic pain, unexplained weight loss. Unfortunately, again, that means the cancer has significantly spread, and leg pain. Just because the cervix cancer sits just above the pelvis, so it can cause pressure on the legs. So going to breast cancer very quickly. What is breast cancer? This we know now, it's a disease where cells in the breast tissue divide and grow without control. So normally body cells are going to have a stop and they stop dividing at that point. But cancer cells just have no stop sign. They just continue growing and growing and growing to infinity. So what causes breast cancer? This is the million-dollar question. The simple answer is that we don't know most of the time. In fact, I'd say about 70% of the time, no one knows what is going to be causing the breast cancer for this particular person. But the other times, the hot factor that is going to be a risk factor is being female. Yes, some men do get breast cancer, especially with a very strong family history. About 4% of breast cancers are going to be in the male population. So being female, of course, is going to be the biggest risk factor. Getting older, we know that the average age of breast cancer diagnosis is in the 50s, 60s. Inherited issues. These are I don't want to bog you guys with the medical jargon, but I'd say family history, dense breast, high blood estrogen levels. So what does that mean? This is important. It just means a lady has a lot of hormones circulating in the body for a prolonged period of time. What does that mean again? So one, if you've exposed yourself to, for example, oral contraceptive pills that are majorly estrogen heavy. So it means in your body, you've exposed your breast tissue for a very long time to hormones. If you started your periods very early on, I know some women start their menses, I don't know, maybe even 8 years or so, and the menopause is very late. It could be almost towards the lady has a huge amount of hormones. Hormones, especially estrogen hormones, can cause breast tissue to grow very fast. And when it grows, there's a high risk of developing cancer. So previous history of breast cancer is a big factor as well. No children or first child after 35 years. Again, all this means it's just the hormonal manipulation in the body, exposing the breast tissue to hormones again. Overweight is important because it's something that we can do something about. Overweight, it means you have a lot of fat in the body. If you have a lot of fat in the body, some of this fat is going to be converted to hormones. The hormones I'm talking about again are estrogen. If it's converted to estrogens and you have too much estrogen in the body, it's going to affect your breast tissue and eventually cause cancer. So being overweight, it's not good as a risk factor for breast cancer and many other cancers, by the way. So fears, no physical activity. So again, just a clarification, being overweight, you may not be overweight, but you may be, so you may be slim, but you're not physically active. Maybe you sit on your desk, I don't know, 12 hours a day. So that causes a lot of inflammation in the body. Inflammation in the body very easily causes cancer. So again, you may not be overweight, but please still be physically active, and not breastfeeding as well is a huge thing. So get screened, discuss with the healthcare provider about which screening test is the right one for you, especially for those ones who are at a higher risk. A mammogram is recommended from the age of 40 for every woman, especially if you're at average risk. Average risk, we just say it's every woman. And I believe a lot of women were at risk, because if you imagine 1 in every 8 women is going to get breast cancer. I mean, let's just get the mammograms done. Then a clinical breast exam every 3 years, starting at age 20. So a clinical breast exam just essentially means when you go to a doctor for anything, it could be even for a common cold or whichever illness. And every 3 years, just mention to the doctor, please examine my breast. I do examine them myself, but I'd also like a professional opinion that everything is okay. Breast self-examination is very important. The whole point of this is get to understand your breast. Because when you understand your breast, if something is not right, then you'll easily pick it up quite early on, and you'll be able to seek medical advice if it means anything significant. So this is the, it could be in any way. I mean, this is just a guidance, but whichever way that you could just do your own pattern. Ideally, we do either a clockwise motion or anti-clockwise motion. Make sure you squeeze the nipple to see if there's any discharge. Look at the skin. Are there any changes on the skin? Does it feel warm? Is the skin changing in color? All these things are things to consider. So whichever way that works for you, it's fine, as long as at the end of the day you understand your breast. So important is raise your arm rather, so that you can free the breast tissue from the muscle in the chest, and then palpate in whichever way. As I said, mostly it's going to be in the clockwise direction. As long as you understand your breast, so that if anything you can pick, you pick it quite early on. So diagnosis involves mammogram. So first of all, we're going to feel something highly likely. That's the most common way patients present. Daktari, I felt a lump in my breast. We do mammogram or ultrasound of the breast. All these are imaging, they're pictures, to put it in the layman way. And then a biopsy has to be done. Biopsy has to be done. No one should tell you this is cancer without getting a biopsy. Essentially, this means going in with a small needle and getting a small sample of this tissue, and it's looked at in a laboratory, and that's going to give us the answer. Is this cancer or not? So treatment is, all these are treatments for the breast cancer. They can be in whichever order. I know most of us have had either family, relative, friend, classmate, whatnot, who have been affected by cancer. And the thing is, one or the other is going to offer advice. Oh, why are you starting with chemotherapy? For me, I went through surgery first. Your doctor is lying to you, or this and that. No. I mean, I know there are patients who are going to start with surgery treatment. There are some who are going to start with chemotherapy treatment. It's very individualized in this day and age. So again, as I mentioned, it's very personalized treatment. It's based on very many things. The report from the laboratory that's going to tell us the biology of the cancer, what stage it is, the health and age of the patient. For some, they're so frail, maybe because of other issues, diabetes, hypertension, heart failure, and whatnot, that we decide, no, this patient, as much as they need chemotherapy, I'm actually causing more harm than good in giving chemotherapy. I think surgery is enough. So, I mean, all this is very, very individualized, and very important is that personal preferences. Some people just say, imagine I don't want your treatment, I'm going to go through Mitishamba. And that's also okay, as long as they have all the information to make such decisions. So third, we have colon cancer. This is bowel cancer, the large intestines. It's number 5 of new cases in Kenya. It affects men and women. Men just a bit more than women, and screening saves life of this disease. So more than 80% is going to be diagnosed above 55 years old. The lifetime risk for getting this cancer, as I said, is slightly higher in male than female. We can see it's 5.7% in men. Also death from the disease can lag behind a bit for the men. No, for the female rather than the men by 10 years. So the men in this group of cancer, they're just a bit unlucky. So what are the, risk, if we may call it? Increased age. This cancer is going to be more in the elderly population, male sex, Black race. So that, of course, is us. Now, very recently, we know now that it's higher, the incidence is actually higher in the Black population rather than the Caucasians or even the Asian population. And that's why a few of our guidelines are now recommending that we start screening for colon cancer so for them, they're going to be African Americans, but for us, we're going to say for our population just a bit earlier than the recommended 50 years. Now, disclaimer, we don't have research particular in Kenya. In fact, a lot of our guidelines are going to come from Western data, but still we go with this. Hello? So these are the risk factors for colon cancer. Now, hereditary risk factors, these are factors we can do nothing about. Unfortunately, family history, some syndromes for colon cancer. Now, other factors that we may be able to do something about, these are drugs, the top 3, the other factors, aspirin, menopausal, statin, those are drugs that you should be discussing with your medical healthcare provider. Ethnicity, Black race, again, we can't really change our race at this point, so there we go. Male gender as well. Unfortunately, patients who have type 2 diabetes and inflammatory bowel diseases. Some people have these conditions that affect large intestines that are not cancer, but they affect the large intestines. These people, unfortunately, have a higher risk. So moving on to the right, we have the modifiable risk factors. Things we can do something about. These are modifiable, we can modify. Smoking, let's reduce that or stop completely. Processed meat, unfortunately, sausages, the salamis and whatnot. In fact, just I think about 2-3 years back, WHO released a statement that these processed meats are category 1 risk for cancers. So if we are used to having sausages for breakfast, maybe it's time to start reconsidering reducing this kind of processed meat into our diet. Alcohol intake, some research is saying is excess alcohol intake. Some research is saying any alcohol intake. So I'd say let's consider alcohol intake at all as a risk factor for cancer, especially colon cancer. Red meat. Now this is a big one. I know a lot of my patients are asking me, Daktari, niache kukula nyama? The only cancer that has evidence for being a huge risk factor for getting the disease is colon cancer. This is not the case, for example, for breast, for cervix, for prostate, for any other cancer. Just colon cancer, it is advised not to have red meat more than twice a week. So that's important. Low intake of vegetables and fruits. So we say fiber diet, low fiber diet is a risk for colon cancer. Body fat and obesity, I had explained about this. This other bit, the lower right box is just highlighting things that we can do that are going to reduce our risk of ever getting this disease. Physical activity. we have to be active, whether the body fat is high or low, you still have to be active. Whole grains. So these are, so when I say whole grains, I'd think of oats, I'd think of the brown chapatis and the brown rice and the brown ugali, because this is not refined carbohydrates. When they refine the carbohydrates, they remove the fiber, they wash out the good stuff from the diet. So as much as we can, we should be able to be taking the whole grains. Dietary fiber, the vegetables and the fruits as well is important. Fish intake, by fish intake, I would also add on any white meat is better than the red meat. The nuts, vitamin D, C, and others, though this is also controversial in our field. Some research is saying, no, it doesn't work. Some is saying it works. And calcium supplements have also been shown to reduce the risk of this disease. So for screening, what can we do about it? First of all, screening has contributed a lot in reducing the deaths in the West, because these guys have been very vigilant in screening their populations. So is screening appropriate for you? I think that's the question we'd all ask ourselves. What do we need to know if screening is appropriate for you? What is your risk level? Are you average risk or high risk, or what's your risk level for getting this disease? Do you have any history of screening or surveillance? What is your age? Remember, the above 50 are at a higher risk for getting this disease. Are there any comorbidities? So what comorbidities mean is essentially, are there any other diseases apart from this one we want to screen? Comorbidities would mean high blood pressure, diabetes, gout, kidney disease, all those are comorbidities. And what is the preference? Does this person want screening that frequently, having all the information as well? So I mentioned risk groups. We have average, increased, high risk, and highest risk. Most of us, without going too much into detail in this slide, most of us are going to fall under average risk. What does average risk mean? I have no sign or symptoms of having cancer or any of these risk factors. So that would be family history of any diseases affecting the large intestines. There are significant risk factors that I'm sure if you've ever been on interaction with a healthcare provider, they'd be on high alert, like, there's a risk here. Maybe we should be doing screening much more frequently. So at average risk, that is most of the population anyway. Let me just summarize this. We have, how do I say this? 2 ways we could screen. One is simply by stool. Every 1 to 3 years, we can just be testing the stool specifically for DNA, for gene material from cancer cells, and that is adequate. This actually saves lives. The second way to screen, and who deserves what sort of screening, is a discussion you should be having with your doctors. The second way of screening is a colonoscopy. So what is a colonoscopy or sigmoidoscopy? This essentially is a camera, a tube with a camera at the top of it, going through the back passage and up into the large intestines, visualizing the whole of the large intestines to screen if there's any suspicious swellings or wounds or warts that could be cancerous. So that's also a good one. That's done every 10 years, by the way. For some, we do every 5 years if we figure out this is someone who may be at a higher risk. Okay, what age? 50 to 75, it is recommended. Please try to get screening done, whether it is by stool every 1 to 3 years or is via colonoscopy. Whatever you decide to have done after discussion with your doctor, just get it done. If we're going to screen anyone between the ages of 76 years to 85 years, it's going to be on a case-by-case basis. You see, sometimes in this age group, these people have so many other diseases that are going on that it doesn't make sense to add on one. Even if you do find colon cancer, for example, at 80 years, you may not be able to treat this person because your treatment is actually causing more harm than good. So it's really on a case-by-case basis. We may screen, but not really. Then we may screen, we consider screening if not up to date with screening and the life expectancy is at least 5 to 10 years. Again, this is a contentious issue because how do you decide this person has a life expectancy of 5 years or not? So this is just a discussion between the doctor, the patient, and sometimes even the relatives. They're there and say, you know what, it's not worth it for maybe our grandfather to get a colonoscopy at this point. We don't recommend any screening to be done for above 5 years for obvious reasons. So this is relevant to us. Should Africans start screening before the age of 50? Now, I don't know, maybe us guys are conversant with the very recent death of the Black Panther star. Now I'm forgetting his name, but this guy unfortunately died from colon cancer, and we know he was very, very young. So this, of course, sparked a lot of research, you know, dusting off the papers, or what has been happening, what's been going on. And what came up is that actually Blacks, African Americans, they have a higher risk of getting colon cancer much earlier than the Caucasian counterparts, Asian counterparts. So for example, you take a Black man and a white person, the Blacks are going to get colon cancer much earlier. So some guidelines have actually changed, and they're recommending we actually start screening way, way earlier. As you can see, the American College of Physicians, they're recommending screening for Black people should start at age 40. While we know for the Caucasian population, it's recommended to start at 50 years. Again, we don't have our own Kenyan studies. Unfortunately, our data collection has not been up to date. But if we are going to extrapolate from this data in the America from African Americans, we can also apply it to us. Because even in my practice, I have seen a lot of colon cancer in very young people. I mean, I've seen colon cancer in an 18-year-old, and not one, I think I've seen 3 of them. So if it's going to be early, it's going to save life, then we do it. Finally, this is the last one, prostate cancer. So who has a prostate? A male. Man, male, it's a male organ. It's a male sex organ. It's the size of a walnut, that's a nut, we know. It's located in the pelvis, in front of the rectum, that is the back passage, and behind the base of the penis. So it surrounds the urethra. The urethra, that's where the urine passes through, and the main function is seminal fluid production, which aids transportation, nutrition of the sperm. So this is a very, very, very common cancer, by the way. What are the risk factors? Age, number one. It increases with age. You know, before we knew all cancers are a disease of the older population. Unfortunately, this is gradually changing. And as per WHO predictions, by 2030, I believe the age is going to be even lower. But traditionally, we know prostate cancer, for example, after age 50, it increases in incidence. Race. Unfortunately, again, our men, Black men, are going to be diagnosed more with prostate cancer than other races, and they are going to die more for prostate cancer than other men. Why is this? Black men get a particular form of prostate cancer that is highly aggressive. So if you look in the laboratory at 2 samples, one is from a Caucasian male and the other is from a Black man. The Black man cancer is a particularly aggressive cancer that grows very fast, spreads very fast, and kills very fast. So, you know, this is just a point to note. Family history, again, is a big one. Eating habits, I just wanted to highlight this again. No study has been proven that any sort of diet or nutrition is going to prevent the development of prostate cancer. So prevention, we currently have no proven way to completely prevent prostate cancer. So I didn't want to go too much into the screening for prostate cancer, just because even within our own field, it's very controversial who should be screened. And maybe just if I could mention something about that, is that most prostate cancer is actually, you see, most men with prostate cancer die of something else and not the cancer. So it begs the question, why am I screening for something that I will never be treated for? Likely I may die from high blood pressure or a stroke or whatever. So most prostate cancer, we say it's low grade, if I may call it that, and it's not going to be any compromise to this patient's life. So the screening bit of it is a bit controversial. So with discussion with your doctors, you may come to a conclusion. You know what? I think let's do screening for you, and we do this by a blood test, a very simple blood test, prostate specific antigen (PSA). Maybe some of you have heard of this test. But it's not for everyone. Honestly, cost effectiveness, health economics, it doesn't make sense to screen everyone for prostate cancer. And that's it for my presentation. Thank you. I welcome any questions.
Thank you very much, Dr. Amina. So to the care team, anybody needs any clarification, any question, you can ask Dr. Amina. She's here to answer your questions. There are no questions. I believe everybody understood the topic. So thank you, Dr. Amina. Maybe Harrison, if you have anything to say before we close. Harrison?
No questions at all?
Clearly, it looks like, well, what I know is that basically the topic is deep. It is so deep.
We can't hear you, Harrison.
Okay. Now, am I clear?
Yeah.
Oh, thank you. Thank you. Sorry for that. I mean, it was just my mic issue. What I'm saying is that, well, I don't know whether there's anything in the chat in terms of a question from my colleagues, but then what I'm saying is I know this is a fairly deep topic with issues that probably need people to just take time and think through and soul search and see that kind of thing. Maybe over time, questions are likely to come up. But then from where I sit, I would say it was it was brief, but very informative, because these are things that affect us. I mean, there are things we see around us. There are things we know they happen. And most importantly, when we get this kind of a conversation or in this kind of a forum, we are better placed to know the things we can do to try and prevent some of these things from happening to ourselves and even the people around us. So maybe I return back to Janet. Maybe there could be some questions from colleagues, maybe in the chat, maybe there's something in the box which can be responded to by Daktari. But otherwise, I would just say thank you so much, Daktari, for taking time to talk to us. And Janet, yet again, I'll just say thank you so much for making this happen. You know, we owe so much to you. We are so grateful. And I want to believe that it's been beneficial even to my team, my colleagues. I mean, it was worth it. It is something that was really worth it. We say thank you so much to Team Aga Khan, starting from Daktari. Any other of your colleagues would be part of this forum. And to Janet, thank you so much. Back to you, Janet. Thank you.
Thank you very much, Harrison. Just to note that most of the times we always offer, as Aga Khan Hospital Mombasa, we always offer some discounted tests, yeah, for cancer. It can be breast cancer, cervical cancer, prostate cancer. We've never tried colon cancer, maybe we'll do it next time. But when you see such kind of notice from Aga Khan, take advantage and just get to know your status. And to Dr. Amina, maybe you can share how you can be reached.
Thank you, Janet. I am at Aga Khan Hospital, Mombasa. My office is on the first floor. If you want to reach out, please come, we can talk, we can discuss screening, treatment, advice, whatever that is needed. Thank you.
Thanks, Dr. Amina. Dr. Amina is a resident oncologist. So anytime you need any help, please, we are open. She's available. Thank you, Harrison. Thank you, KRA team. Since there's no questions, so I wish you a very warm evening. Thank you. See you next time.
Asante sana. Thank you so much. Good evening too. Thank you.